Hello, hello. My name is Luan Nguyen, and I'm a MAVEN physician volunteer. Thank you all for joining us today. And our friend and Anchor Clinic, thank you for hosting today's session. Our session today is Screening for Colorectal Cancer. 45 is the new 50 by Dr. Scott Nelson. Dr. Nelson is a practicing general and colorectal cancer surgeon as assigned Three Rivers Medical Center in Grants Pass, Oregon. He's currently serving as Chief of Staff and Medical Director for ASCENT, Physician Partners, 15 specialty clinics. He has been in practice for 15 years. He's a frequent lecturer for the General Surgery Review Board and has served on the Clinical Practice Guideline Committee for the American Society of Colon and Rectal Surgeons. Dr. Nelson's areas of expertise are rectal cancer, diseases of the endorectal region, and endoscopy. He serves on various hospital and clinic committees and boards and chair of his local school board. So welcome, Dr. Nelson, and thank you for sharing this with us today. I'm going to hand it over to you, Dr. Nelson.
All right. Thank you very much. Thank you for the invitation to come and speak on one of my favorite topics to talk about, which is colon cancer screening. It may not be anybody else's, but it certainly is mine. And we just want to highlight some of the changes that have happened over the last few years. 45 is now the new 50. And so we're trying to spread the word to encourage people to be screened at a younger age. So again, I'm grateful for this opportunity to speak. Let's see if we can't move our slides along here. So I don't have any disclosures. As was pointed out, there is CME credit available for this talk today. And I am very happy to entertain any questions or comments after we finish up. Here's our learning objectives for today, though. We want to really be able to categorize the patients that we see into a risk category for colon and rectal cancer. Putting them in that risk category really helps us stratify the best screening modality for each of our patients. We're also going to talk a little bit about the different screening modalities and what opportunities we have to offer patients. And then lastly, it's to select the appropriate modality for the appropriate patient and make sure that we're getting the patients that we see the right screening tests so that we can prevent colon and rectal cancer. So just as kind of a brief highlight of what we see in the United States with regards to cancer, breast and prostate cancer are the two most common cancers that we deal with on a regular basis. Lung cancer is next, and then colon and rectal cancer comes in fourth. However, you can see that lung cancer is the greatest cause of death from cancer, and colon and rectal cancer comes in second. And so each of these has a screening modality or component to it. We do mammography for breast cancer, PSAs, and physical exam checks for prostate cancer. Lung cancer, there are screening tests for the high-risk individuals. Colon and rectal cancer is one of these areas where I think we can make a significant difference, and that's because as opposed to screening with breast cancer, prostate cancer, or lung cancer, we can prevent people from getting colon and rectal cancer. And we do that by finding and removing polyps. And so this is a number that I think as practitioners, we really can make a huge difference in our patient population on. You can see that over the years with increased screening, we are making a difference. In 1992, the incidence of colon and rectal cancer, the rate per 100,000 was 57. And today, or not today, but in 2020, you can see that that number has decreased significantly. And that is because of an emphasis that has been placed by our primary care providers and frontline staff on encouraging people to be screened for colon and rectal cancer. I think there are some important data points, or at least facts, that we should know. The first is that you have a 4.1% risk of developing colon and rectal cancer in your lifetime if you are considered average risk. And so everybody is at risk, at least in a small way, of developing colon and rectal cancer. 94% of cancers are diagnosed after the age of 45. And so while we do see younger patients, it is a disease of age. And the 5-year survival rate for colon and rectal cancer is at about 65% all comers. However, if we take just stages 1, 2, and 3, that number goes up significantly. We are getting much better at treating even metastatic disease, but certainly we're getting much better at treating our stage 1 through 3 patients who have colon and rectal cancer. So the U.S. Preventative Service Task Force, this is where most of our information is coming from today, has a number of risk factors for colon and rectal cancer. The first risk factor, and probably the most important, is age. As we just mentioned, you have a 4.1% risk of developing colon and rectal cancer as just an average adult. And so as we get older, that risk is that's when we see the risk. We have our minorities as well in the United States are at slightly higher risk for various reasons. Family history of colorectal cancer, even without a known inherited syndrome, increases your risk significantly. Men are at higher risk. We know that obesity, diabetes, long-term smoking, and unhealthy alcohol use all contribute. One thing that I will point out that they didn't put in that I do think is a contributing factor, though, is our diet. We know that a diet high in red meat is also a contributing factor, or a lack of fruits and vegetables. So a high fiber diet with less meat also seems to be protective against colon and rectal cancer. But the real question is, when you sit down with a patient in the office and you're talking to them about colon and rectal cancer, we need to know, where do we start? And so for me, this is just a very easy way to start looking at what test should I order for an individual. And we start by assigning them a risk category. And so this slide, I think, highlights the 3 risk categories that we see. So the first risk category that I'll talk about is increased risk. So an individual is at increased risk for colon and rectal cancer, and that again is higher than the 4.1%, which is just the average risk. If you have a first-degree family member that has been diagnosed with colon cancer, your risk of getting colon and rectal cancer is increased significantly. Also, if you have a personal history, if you've been screened previously, if you've had colon polyps or a history of colon cancer, you are obviously at higher risk. Our patients with inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, that chronic inflammatory state increases their risk for the development of colon and rectal cancer. And then also cystic fibrosis patients are at increased risk. So that's really the category that I start with. Is this person at average risk, which means they don't have any of those risk factors, or do they have some risk factors that makes me perk up and pay a little bit more attention? The next risk category is genetic risk, and these are individuals that have Lynch syndrome, HNPCC, or any of the polyposis syndromes such as FAP or attenuated FAP, and you can see them all listed there. These, thankfully, are rare. We don't see many patients with these genetic syndromes. However, they are present, and if you identify someone with some of these risk syndromes, these are individuals that really should be managed by gastroenterology and or a colon and rectal surgeon, because their treatment algorithms are significantly different than everyone else. So really, we're just going to focus on the average risk individuals and our increased risk population today. And so that's a very good place to start as you're meeting with patients, is to think about, where do they fit in their risk for developing colon and rectal cancer. So let's start with our average risk population. And if you have someone with none of the risk factors that we've talked about today, thankfully you have lots of options to offer them for screening. And really the most important thing for this group is just to help select any option for them. We want everyone to be screened for colon and rectal cancer. And so there are stool tests. You can have endoscopic and even radiographic means of screening, and we're going to go through some of those today. So the stool tests, these are very simple tests to perform. The patients obtain a stool sample. They usually have to take some of the stool, put it on a card, and they'll send it in to the lab, and the lab analyzes it. So there's no drinking of bowel preps. There's no procedures involved. It's, maybe a little gross. No one likes to have to play with their stool, but that's kind of the worst of it. But this is a very simple safe test to perform. And there's 3 different types of tests that are currently available on the market, or maybe they're the most popular. The first is a FIT test, that's fecal immunochemical testing. And these detect blood using antibodies. It's a much more specific and sensitive test than a fecal occult blood test. They're very good at identifying blood or other products in the stool that may be a contributing or a marker for colon polyps or colon cancer. It's recommended that FIT testing be done every 2 years, and it's a relatively inexpensive test. It costs about $20 to $50 to do. If the test comes back positive, then we would recommend that the individual be screened with a colonoscopy. Fecal occult blood testing has been around forever. It just detects heme. It does have a high specificity, though it's unfortunately not always very sensitive because it can pick up heme from lots of different things, including our diet, diet high in protein. It will detect the hemoglobin in animal meat. And so these can be false positives often. They do recommend that this test be done annually. And it again is a very cheap test. It's about $20 to $50. And if it comes back positive, we recommend a colonoscopy. One of the problems that I've seen is it is not recommended for screening that we do this test in the office with a rectal exam. And so oftentimes providers will just do a rectal exam in the office and then take some stool, wipe it on the card and send it down. But that invalidates the test from a screening perspective because of the risk of a positivity if you cause some bleeding during the trauma of a rectal exam. And I think it should be rare, but certainly not zero. And so that's just something to think about. The last test is a stool DNA test or a FIT DNA test. And this is the most sensitive and specific for identifying polyps and or cancer. It detects possible DNA changes as the colon is shedding its DNA into the stool. This test can detect abnormalities. And so it's just the best test if you're looking for things. However, it is also the most expensive. It costs anywhere from $500 to $600 for the test. You do get to shorten or lengthen out the interval, so you only need to do this every 3 years. And again, if the test is positive, we would recommend a colonoscopy. So for a lot of our patients, maybe those who are uninsured, can't afford a colonoscopy or their insurance doesn't cover it or they just don't want to have a colonoscopy, these are very good tests to do. And I encourage clinics to seriously consider this and to put into place a practice where it just becomes routine. I think the risk here with using the stool test is that we'll do it once and then it doesn't get done at the appropriate time intervals. And so really working out that process of making sure that we're doing the test appropriately and consistently is probably the most important thing. But these tests do decrease the development of colon and rectal cancer because they are sensitive enough to pick things up, and programs or clinics or institutions that use this appropriately, these are very good modalities. So moving on to radiographic tests, I'll be honest, most of these have fallen out of favor. I don't think we do this often, and I'll explain why, but there are other options, or this is another option for screening for colon cancer. The first that seemed to hit the market with a lot of fanfare was this virtual colonoscopy. It's a CT colonography where they're able to literally drive through the colon virtually as they reconstruct the colon. It seemed really cool and flashy at the time. There were a number of problems with it. The first was that if they found something, you would need to have a colonoscopy, which is not that dissimilar from the stool test. The problem is that for this, you also had to do the bowel prep. So you weren't saving anyone the problems of doing a bowel prep, and if you were nice, you would try to coordinate it so that if you did see something on the CT colonography, that the patient could go right over and have an endoscopy the same day, so they didn't have to prep again. And so that became a challenge logistically, and it also became difficult if they found something and weren't able to do the colonoscopy the same day. The patient would have to prep twice, and if anybody's had a colonoscopy, that's always the worst part. They did have to pump the patient full of gas, so the tube had to be inserted, and they had to put air up inside to distend the colon. And so again, that's the most painful or uncomfortable portion of the procedure, and that's why we sedate patients for colonoscopies. And so you still had to prep, they still had to insert something. And so it just, while it was cool to watch on the screen, from a patient's perspective, it offered very little as far as an advantage. However, one of the other advantages of the CT colonography was that they were finding other things. And so, if there were extra colonic findings, we would be able to detect those. Barium enema was an older test that thankfully has fallen out of favor. That's where patients would come in and they would fill the colon up full of barium and take a number of x-rays, and they could see larger polyps. I think it's a very painful test, and it's not as useful at detecting small polyps. But that is another modality that has been offered in the past that I don't know many places are offering today. Lastly, we have endoscopic evaluation. And so there's two different types. One would be a flexible sigmoidoscopy, and the other is a flexible colonoscopy. A flexible sigmoidoscopy means that you go up to the splenic flexure and terminate the exam. It was oftentimes done without anesthesia. It was recommended to be done in conjunction with either FIT testing or fecal occult blood testing. And it was recommended for people to have it performed every 3 years. We were just talking before about Kaiser and how Kaiser was an organization that for many years did fecal occult blood testing and flexible sigmoidoscopies. And my parents had Kaiser insurance back in the 90s, and my dad went in and had a flexible colonoscopy with his FIT test, and they didn't provide any sedation. And he walked out and said, "I'm never going back. I'm not screening myself for colon and rectal cancer." It was a terrible experience. And so that was one of the realities, I think, of this. It's not that it was bad. I do think that they were catching cancers and lowering that risk, but it was just challenging for patients to undergo those. Which leads us now to the gold standard, I think, of screening for colon and rectal cancer, which is a flexible colonoscopy. And that's where we insert the colonoscope and advance it to the cecum and the terminal ileum. We were able to evaluate the entire mucosal lining. We're looking for polyps, obviously. If that's normal in an average risk individual, then the test just needs to be performed once every 10 years. In Oregon, we use propofol routinely for our anesthesia, which is wonderful. I don't know what is offered in other states. I've trained in Creighton University. We used to use Demerol and Versed, which was a terrible combination to sedate patients. And since moving to Oregon and joining my practicing here, I have found that propofol is the drug that keeps on giving. People love it, and they'll come back and do this test again. And so anyway, I'm just an advocate for colonoscopies with the appropriate sedation. It makes the process much better. So just kind of a slide. We won't go through all of this, but you can see that all of these tests, if done appropriately, are effective for screening for colon and rectal cancer. And as a colon and rectal surgeon and someone who does colonoscopies, I have my own biases on that being the gold standard test, but there are risks with that, and it's not a perfect test. And so there's lots of different modalities, and we certainly encourage everyone to look at the patient and decide what's going to be the best thing for that individual to be screened. You can see that the stool tests do certainly add life years to a population, and they also save lives. And the differences between good FIT testing or stool testing and a good colonoscopy are not significantly different. So it really is just putting a good screening program into place. So that's our average risk population. Again, that's a population that does not have any of the risk factors that we associate with colon and rectal cancer, family history, or inflammatory bowel disease, or a history of polyps. So this next option, though, is much simpler. If you have a patient who has a family history, a first-degree family member, so mom, dad, brothers, or sisters who have been diagnosed with colon cancer, or they've had colon polyps in the past, or they have inflammatory bowel disease, they just have one screening option. The stool tests, radiographic tests are no longer available to them, and that is to have a colonoscopy. And that's because there is a greater risk to that individual, and that they could have polyps or other problems, and those things need to be assessed. And so really, it becomes a simple recommendation at that point. And we base the interval of screening based on the findings. And so if an individual has had colon polyps in the past, then it really becomes incumbent upon the endoscopist to determine when they come back. And we base that on the pathology of the polyp, the number of polyps, the size of the polyps, and probably information that nobody else would have, and that is, how successful were I at removing the polyps? Do I feel confident that we removed it all and that we have a low risk for things to come back? And so the endoscopist is the one who would then make those recommendations. And it can be coming back in 1 year or 3 years or 5 years or 10 years. It depends on the findings. It depends on a number of factors. So not everybody who has colon polyps will be coming back at 5 years, which is the typical recommended time interval. It may be different based on what you're finding. Inflammatory bowel disease, these individuals usually come in every 3 years, and that's because after the 8th year from their diagnosis, which gets a little confusing, their risk for developing colorectal cancer shoots up remarkably. And that's just because of this chronic inflammatory state. We know that chronic inflammation leads to dysplasia, which obviously increases their risk for cancer. So every 3 years, in individuals who have Crohn's or ulcerative colitis, we recommend screening again for them. They may be getting colonoscopies because of their disease process, but certainly from a screening standpoint, you want to do it every 3 years. And then again, a family history of colorectal cancer, we certainly recommend that they come in every 5 years to be screened, regardless if they have nothing in their colon. If they can have a normal colon, we would still recommend a 5-year interval for that individual. And then again, we won't spend much time on this, but our genetic risk patients, again, there's just one option for them, and that is a colonoscopy and really surgery. We have, I'll just speak of the two most common genetic inherited syndromes. The first is familial adenomatous polyposis, or FAP. They have a 100% risk of developing cancer in their lifetime. And it is remarkable. I have a number of patients with FAP. They have hundreds, if not thousands, of polyps in their colon, and it's just not a manageable situation to remove all of those. Those polyps typically start growing in the colon in their early years. I mean, even at 10 or 11, you can find polyps in these kids. And then certainly through their teenage years, they will have developed hundreds, if not thousands, of polyps. The surgical recommendation is to remove the colon typically after high school if we know that they have this, and to give them a J pouch. And that's a whole nother conversation, but it is because their risk of cancer is so high. And not only of colon cancer, but they have risk for many other cancers, including stomach cancer and ureteral cancer, and then in women, uterine cancer. So lots of issues with FAP that we could spend a whole talk on, but if you have someone like that, again, it's just best for them to be managed by a gastroenterology and or a colorectal surgeon. The other risk is HNPCC, or Lynch syndrome. These individuals have about an 80% chance of developing colorectal cancer in their lifetime. They're usually younger as well. I usually find these patients at about 30 or 40. They were coming in with cancers. They didn't know that they had it. And by the time they hit that age, they've now developed a colorectal cancer. We do recommend a yearly colonoscopy. There is strong recommendation for a total colectomy. So we remove the entire colon, we leave the rectum behind, and perform an ileorectal anastomosis. I find that most of my patients just refuse that, and so we end up just screening them on an annual basis and just doing close surveillance. But they are at extremely high risk for developing colorectal cancer, as well as other cancers, just like FAP. So just a little bit about Lynch and FAP, and we can answer any questions if you have, but thankfully that's a rare, those are rare patient population. One of the questions that we often get is, when do we stop screening? And so the recommendation is that we stop screening at age 75. And that's not a hard stop. I think a hard stop is 85. But the recommendations really are this: if we have few additional life years that are gained when we're doing screening past the age of 75. Now, clearly, I have a number of patients who are extremely healthy at 75, and if they've had a history of polyps, I would bring them back and do another scope at 80. But it becomes a conversation where, we as physicians and the patients, we look at their overall health, we look at their history, and we can make some determinations about are we done? Is enough enough? And in most patients, I would say yes. At 75, we quit recommending screening for those folks. And certainly their guidelines are we do not screen anyone after the age of 85, really 86. There's just no need to continue to screen those individuals. Now, older patients, if they're having issues, if they're bleeding, if they have chronic diarrhea or whatever, certainly we would perform colonoscopies. It's not that it's unsafe to have the procedure. We just don't see as much benefit for individuals as as they get older. So 75 is kind of that magic number to stop. So I think just to summarize, the whole goal is to prevent colon cancer. And, unlike many of the other cancers, this is completely preventable. Good screening of our patients has demonstrated over time that we can prevent people from getting colon and rectal cancer. And that's what's so exciting about really this talk is just we have the ability to make a significant impact in someone's life by getting them to screen for this disease. And again, it's an uncomfortable conversation. Nobody likes to talk about their colon. Breast cancer has become almost in vogue. Football players wear pink ribbons on their uniforms, but you don't see any poop emojis on the NFL football players' jerseys because colon and rectal cancer is just not something that we want to talk about. But this is where we can make a significant impact in our patients. So the take-home message from today is really assess the risk of your patient. Are they at average risk? Are they at increased risk? Or is there a genetic component? And then we pick the appropriate modality for them. And I think the reasonable approach is either a stool test and or a colonoscopy, given the situation of the patient. And then stick to it. Make sure that we're doing the test. If we're doing stool tests, make sure that we're doing that on a regular basis and that we're not losing people to follow up. Or if they're going to have a colonoscopy, we make sure that they continue their screening tests in an appropriate manner. So that's really it. I hope to give you at least 30 minutes of your lunchtime. I'm very happy to entertain any questions that you may have on screening for colon cancer or anything else. And I thank you very much for your attendance today.
Well, thank you, Dr. Nelson, for this very clear and concise presentation. I really appreciate it. I have a question for you while I wait for other people to chime in for questioning. So if someone who has a family history, say mom, dad, brothers and sisters, then they need to be screened. Is there a time, I'll say a mother who had diagnosed with colon cancer at age 55, should her children be screened at age 40, or do they need to go to 45?
Yeah, no, that's a great question. Something I probably should have put into the talk. So the recommendation is 10 years younger than the age that the family member was diagnosed with colon cancer. So if the mother was diagnosed at age 50 with colon cancer, the children should be screened at 40. If she was at 55, then the children should be screened at 45. Obviously, if they're older than 55, then we would just screen at the normal appropriate age. But younger patients, if you're younger and you get colon cancer, then that does raise a number of red flags for us to look at screening people at a younger age than 45. And if there's enough people in the family, then that raises some questions about the possibility of a genetic abnormality, and then we would recommend some genetic testing as well. But that's a great question. Thank you.
Well, thank you. The other question I have is if your brothers and sisters have adenomatous polyps, 2 in the family, should that increase the risk of other siblings? and they should be screened for colonoscopy?
That's a great question. So we don't think that just having other individuals, or at least there's no data to support that adenomatous polyps alone confer a greater risk to a first-degree family member. So we would not, for example, if your sister had, a tubular adenoma that was removed, we would not tell somebody, hey, if your sister had that, you should have a colonoscopy every 5 years. That doesn't increase your risk per se. We would certainly recommend a colonoscopy at the appropriate age interval, but not more frequently. It doesn't carry the same risk as having colon cancer.
Great. Thank you. Anyone has any other questions? Please use the chat function or just raise your hand. Okay, one more question. So if the mother had colon cancer at age 70, then they will go into the average risk pool of getting screened at age 45. Yes?
So yes, we would recommend that they start screening at age 45, but that individual, if their mother had colon cancer, would be now considered to be at increased risk, which means that we would do the colonoscopy at 45, but then we would say you need to come back at age 50. So every 5 years, you need to come back in to be screened because you are now at a different risk category because mom had colon cancer. So we would still start the screening at the same time, but we would bring the individual back every 5 years as opposed to every 10 years.
Okay, so it's a family of first-degree relative with cancer of any age, then you start screening at 45 or younger if that person is younger.
Yes,
And then you go for a 5-year program colonoscopy. So your risk is increased because of that. So you go every 5 years.
exactly. Yep,
Yeah.
exactly right.
All right. Any questions from the group? Okay, clearly it's very clear.
Very clear, or they're all asleep. Either one.
So it's just to remind you about the CME, when you close out the webinar today, there'll be a link for you to do a evaluation. Oh, here we go, someone. So Mary Alicia said, excellent information. Thank you.
Thank you. No, I appreciate the opportunity to speak, and thank you for inviting us. MAVEN does a very nice job. I'm just a physician volunteer, but I'm very grateful for all the clinics that we're able to serve and for what you do. So thank you.
Yeah, and when you close out this webinar, there will be a link for you to put a evaluation, CME evaluation, and that way you will get your CME credit. But for some reason you don't get that link, you get the link in the email tomorrow. So thank you for joining us today, and I hope that you enjoyed the session and enjoy other future sessions, and even anchoring a educational session. What that means is that your clinic can request a webinar, and then we can go with your date and time that you want, and then invite other people to join, like what we have today. And if you're interested in anchoring a CME program, please send an email to Kristen Talbot, and she'll help you with that. Just for a little quick advertising for mentoring program with Kaiser, with a MAVEN project, we provide mentoring to providers at any point of your career. Some topics, ideas to reference will be new practice, new providers, challenging case review, prevent burnout, building teams, and executive coaching. Also offers specifically mentoring like EKG, continuous glucose monitoring for any anchor clinic that's interested. So this recording will be available in our website in the next 2 weeks. So and you'll get that information in the email as well. So thank you for joining. Thank you for taking your lunch hour to do this with us. And thank you, Dr. Nelson, for this excellent presentation.
Okay, thank you.